Okay, so we left off here talking about this whole progression of atherosclerosis. And so now we will dive into the other side of that, which is we're looking at the effects of exercise. Okay, so we'll kind of go through piece by piece, step by step, with all of the different kind of steps along the way, and look at specifically how exercise affects each of those. Okay, so since the beginning of damage to our blood vessels is endothelial dysfunction, then we can look at that first. So exercise, what it does something called increases shear stress on our arteries. Okay? Shear stress is, instead of our blood just rushing down through the middle of the arteries, it's pushing out on the walls of the arteries a little bit. Kind of think of it like turbulence flow through a vessel, right? And so by increasing shear stress, this stimulates those endothelial cells to do a few things. So it increases nitric oxide production. And then from that, we could trace that back to a lot of things, right? Because if we go back to the progression of atherosclerosis, we looked at what happens when we have less nitric oxide. After less nitric oxide, and then we have damage to enons, then we produce free radicals, a lot of nitric oxides that we out. We have less nitric oxide, we bring all these cellular adhesion molecules, which adds immune cells to the blood vessels, right? So if we're pretty much reversing that, then lots of things happen with that, right? We get vasodilation. That's kind of an immediate effect. But then when we get less DCAM, ICAM, those things, right? Which those things would decrease inflammation, right? Because those things are what call in the immune system. So if we have less of those, and we have less macrophages in there, less T cells in there, all of that. And then also with the DCAM and ICAM and nitric oxide is also an anticoagulant too, right? So we decrease blood clotting. Well, right, so those are pretty just drastic effects of that nitric oxide production, right? And so part of this is from improved enos function, right? And when we do that, then we decrease free radicals. And if we decrease free radicals, then we decrease oxidized LDL. And so then that's going to intersect that whole process of the macrophages engulfing LDL and all that. Right? So those are some important pieces there. And just kind of overall improvements. Really will help. Yeah, so there's a lot that comes from that, right? And there's a difference again between just a little bit of added shear stress for your whole life, like we get with hypertension, right? That tends to be a stress on our blood vessels that damages blood vessels and damages endothelial cells. But if we have periods of highly increased shear stress for maybe 30 minutes to a couple hours a day when we're exercising, and that tends to have good adaptation. Whereas just that little bit of extra stress all the time with hypertension tends to lead to that. Okay. Questions on any of that, or those connections that I drew there? Okay. So there's been a lot of debate as well as a lot of research on this question, like what type of exercise is the best for our blood vessels, right? And HIIT, which a lot of times has the second I in there too, but high intensity interval training has been one that's been researched quite a bit to look at maybe this is actually better for our blood vessels than just kind of continuous, more moderate exercise. And so we'll talk about that a little bit. That was the exact topic of my PhD dissertation. And so we'll talk a little bit about that study and some of the stuff too. So this is my dissertation study. We finished, these are the subjects that finished the study. Yeah, go back to one slide. Sure. Yeah, so these are the subjects that finished the study. So at 18, the inclusion criteria was to be obese by BMI standards. Okay, so BMI of 30 or above. And then otherwise healthy adults, but they had to also be sedentary, right? So they couldn't already exercise. And they just did 8 weeks of training with us. So 3 days a week of either hits or continuous. And the hit protocol we used was a 10 by 1. So it looks something like this, where they have they warm up for 5 minutes and then they do minutes of super intense exercise. Okay, so a minute of exercise that would get them to about 90 to 95% of their maximum heart rate. Do that for a minute and then they go back down, kind of cruise for a minute and then back up for another minute. Do that 10 times. This one tends to be a little bit more doable for people that of lower fitness levels versus like a 4x4 type protocol. Has anybody played around with these types of workouts? Yeah. Have they tried the 4x4? Yeah. Yeah. So that's like 4 minutes at high intensity, and then 3 minutes of kind of cruising, and then 4 minutes back up. But only doing it 4 times instead of 10 times. But that one, I mean, some people find that one easier than the 10 by 1 just kind of 10. But this one tends to be a little more feasible for people who don't normally work out a lot. So that's what we did. This is all on the bike. The HIIT workout was much shorter versus the 30 minutes at 75% of max heart rate, which is kind of continuous. That was 40 minutes total versus 29 minutes total. So yeah, total of about in the 8 weeks, almost 5 hours less of exercise if they're in the HIIT group. Right? And that's always one of the big things about HIIT. It's like, even if it doesn't have better results, if it has the same results and you did it in that much less time, then that's one of the things to talk about. So yeah, so that was the study, and the main outcome of the study was a measurement of endothelial function, which is called flow mediated dilation. Most people just know this as FMD. Okay, and what we do with FMD is we take a high resolution ultrasound machine. Yes, and we take an ultrasound machine, look at their brachial artery right here. Okay, and so we look at that brachial artery, we get the diameter of it while it's resting first. Okay, while it's laying there, it rests for 15 minutes, and then you come in with the ultrasound machine, get a view of that brachial artery and measure it. And then what we do is we put a blood pressure cuff on their forearm like this, and pump up that blood pressure cuff to the point to which no blood is going past it. So you put up about 250 millimeters of mercury, so you cut enough blood flow in their hand, and then you do that occlusion for 5 minutes, and then you let that pressure off, and then let the blood rush back in. You get what's called reactive hyperemia, which just means like the body's trying to make up for that lack of blood flow for 5 minutes, so it sends a bunch of blood down there. And what that does is create a ton of shear stress, and so all that blood just tries to rush back in, pushing on the artery walls. That stimulates those endothelial cells to release nitric oxide, cause vasodilation. And so really it's a test of an artery's ability to release nitric oxide. So it's a good non-invasive measurement of endothelial function. So much so that we know from big studies that put a bunch of data together called meta-analyses that so a tip like a normal FMD percent is a 7% dilation going from resting level to the peak level. So this is what we expect to see that diameter increase after the release. 7% is normal. Okay, if somebody's 6%, then they're 13% more likely to die of a heart attack if by 1% decrease. So every percent change that they have in FMD is a 13% increase in the likelihood of having cardiovascular events, so heart attack and stroke. So it's a very predictive measure. And even though you're measuring it in the arm, it's very predictive of what's happening in the coronary arteries too. There's been studies that kind of measure both at the same time to see that they kind of are similar. And so it's a super non-invasive way to look at endothelial function. Yeah, questions on that? Yeah, so what this kind of shows the physiology of how that would happen. Right? So this is one endothelial cell here. This is your blood vessel of where the blood is passing through. Right, so those endothelial cells have little proteins on the outside that are mechanoreceptors. Right, they're actually sensing that pressure from that blood flow when we have shear stress, okay? And so the FMD test causes a lot of shear stress, stimulates those mechanoreceptors. The mechanoreceptor will kick off a whole series of cellular events that leads to the activation of that enzyme, eNOS. Right? Kick off eNOS to start doing its job, which would be to make nitric oxide, right? And so that nitric oxide is produced. It's released down this way, not into the blood, but into the media of the layer of the vessel, where the smooth muscle is, right? The muscle layer of the vessel. And then it causes that causes the damage. So that's the whole process. This process takes about 60 seconds, actually. So we don't expect to see full dilation like immediately. It takes a while for all those little, that whole chain of events to happen. So we release the blood pressure cuff, and it takes about a minute to see peak dilation, typically. Longer people that have some cardiovascular disease. So I don't think these are going to work here, but let me pull them up on my computer real quick because it is worth a second to show this. Let me open up the PowerPoint on my computer to show you these little videos. This is exactly how we do the test, and this is the yeah, these are actually screen recordings of the software we use to analyze this data once we get it. Okay, so yeah, so this is the ultrasound image right here. This is the brachial artery right here. We can actually see the brachial vein down there as well. We put a little Doppler probe in there. You can, in the ultrasound machine, you can move that little Doppler probe wherever you want, and that's picking up any movement. So that actually measures velocity of the blood flow too, which is shown right here. So we see with each beat of the heart, it spikes, and then we get a little bit of backflow with each beat as well, which you don't always expect, but that's blood moving forward, that's blood moving backwards, right? Then it's between beats, blood moving forward, blood moving backwards. Okay, so that's just picking up that. And then this graphs those things. This graphs the diameter of the artery. So the diameter is just the average of the distance between hundreds of points between those two little things there, right? And then this is graphing the speed of the blood flow, and that's graphing actually mils of blood flow. So I'll just show you what it looks like. At this point, we've already done the 1 minute of occlusion. That's what this is. So we're 50 seconds in to that period where the 5 minutes of occlusion has already happened. And then we're going to release the cuff, and you'll see the blood pressure shoot way up, or the blood flow shoot way up. And these should go together here. I think I might have. Yeah, so they're kind of going together there. So you can see the kind of real-time graphing happening. And then right about here, we'll see the blood pressure cuff release. You can see that big increase in flow, but diameter hasn't changed at all yet, right? So see a huge increase in velocity and flow. This is like the tingliness is all in their hands right now. Had this test done on me around 100 times because all PhD students had to practice on each other a million times before we could do it. But still no real increase in diameter, but it's just starting to right now, right? After about maybe 40 seconds in, we're starting to see it creep up a little bit there. Yeah, but flow is starting to drop back down now, right? And now you can finally see diameter creeping up, right? And so that's that vasodilation that we expect to see. Yeah, and then we can, yeah, then I'll just go back to the other screen here. So then what we do after we get those measurements is we put it into this other software where it does some calculations for us, right? So it's looking for baseline diameter here, and then it's looking for the peak diameter there after the occlusion, or after we release the blood pressure cuff. And so then we can see those results right here, right? So baseline is 0.219 centimeters, right? So it's very small, okay? And then it increases up to 0.228, okay? So that's a 4% FMD. This was one of these subjects in my study before they started exercising, when they were still sedentary, okay? So that 4% FMD, that means that person's about almost 40% more likely to have a heart attack than someone who has a normal FMD of 7%, right? So, but this is somebody that has no idea they have any disease process going on at all, right? There's no symptoms, no nothing, but this just shows you kind of how early on endothelial function declines in the process of the disease. So yeah, so what did we find in the study? So these are our two groups. So we have our continuous group in the black line, HIT group in the red line here. They started at a similar spot, somewhere around 5-ish% is where they both started. Okay, we can see that the HIT group went up to, it almost doubled, right? Went up from 4.5% to 8.5% in their endothelial function change in those 8 weeks. Okay, and the continuous group almost looks like it goes down there. That wasn't actually a significant decrease in FMD. So the continuous group didn't really change their FMD, surprisingly. We didn't really expect that finding, but definitely looks like here the HIT was better in this group of subjects for FMD. But we also looked at some other things. This is the resting diameter of the artery, and then that's the peak diameter. The thing that was interesting that we saw was the continuous group, their arteries actually just got bigger. So their resting diameter was actually bigger. So there's really two types of adaptations we can expect to see with training in arteries. One would be a functional change, like the arteries respond better to stress. That would be the FMD one. But then the other would be a structural change, like the artery actually just changes its structure in such a way where it gets bigger to allow more blood flow. So it looked like we saw kind of a structural adaptation in the continuous group, which is good as well. And then we saw that functional adaptation in the HIT group. So it was kind of an interesting finding. But yeah, so that was that one. Questions on that? Yeah, so there's a good collection of research on this now, and yeah, it tends to be that HIT probably is a little bit better for improving FMD, but there's still great results from continuous. There's plenty of other studies that show kind of continuous moderate exercise also increases FMD. For some reason in this study it didn't, but there's plenty of other studies that show that it does. So some other stuff that's interesting in the HIT literature. This study is an older one now, about 15 years old, but it was the first study that. Go ahead, Cole.
Yeah, I was going to ask like,
yeah.
the like long-term effects of like HIT continuous.
Yeah.
Like which one's better?
Yeah, it's a great question. We don't have a lot of long-term studies with those two, but you know, so they're probably we don't have any real like long-term HIT studies. We have studies where long-term studies where they did like vigorous continuous exercise versus moderate continuous exercise. And some of those results are really interesting. There's one study in particular called the STRIDE study that it's massive randomized control trial where they had thousands of subjects in it, but they went for over a year and supervised exercise for over a year. Some of the subjects ran 20 miles a week. Other subjects walked 20 miles a week. And then there's a few different groups, but that one, it totally depends on which outcome we're looking at, which one's better. So they measure blood pressure, they measured insulin levels, they measure glucose levels, they measure weight loss, they measure different markers of artery function. So there's all kinds of different ways to look at it. But one of the interesting parts about that study is that it seems to be the volume of exercise is the more important factor than intensity of exercise when it comes to, especially when it comes to things like insulin resistance, so for diabetes type markers and blood pressure, volume tends to be the more important factor. So the ones that ran 20 miles a week didn't have any better improvements than ones that walked, I think it was 12 miles a week, because that took the same amount of time. It was about the same amount of time to walk 12 miles a week as it was to run 20 miles a week. And so, yeah, you might be kind of pissed if you're in the running group. It's like, I ran that much. But it was the volume that actually was the key factor for that. There were a couple markers that might have been better for the intensity. Trying to remember what they were, but definitely blood pressure and those diabetes type factors where volume was the key component of the prescription. But again, that wasn't HIT either. Right? That was vigorous. So it'd be running continuously versus walking continuously. We don't have any long-term studies on HIT, like year-long studies on HIT. We just don't have that because it takes a while for those to come out, and it's hard to do those studies. Definitely hard to have people do HIT 3 days a week for a year. Right? Like, you know, most young people don't even do that, right? So to get people that are kind of at risk for disease to do that would be hard too, for sure. Yeah, great question. Yeah, Alex. hypertrophy of skeletal muscle, and then connecting that to the artery function in that same area. Yeah, I haven't seen anything on that. Yeah, it's a good question. So maybe kind of what you're getting at is like we're measuring this in the arm, but they're doing leg exercise. I don't know if that's kind of what you're getting at, but yeah, which is kind of an interesting thing. And people have definitely critiqued a lot of studies for that because this is almost always measured in the arm, but then the exercise is almost always leg exercise. But there have been some people that do FMD on the femoral artery too. But it tends to adapt in a similar fashion that the brachial artery does with training. But maybe just a little bit quicker adaptations if you're doing it in the exercising limb versus the non-exercising limb. So yeah, I think there's definitely something there that there's for sure there's more shear stress in the femoral artery during biking or running than there would be in the brachial artery, right? For sure. So you would expect more adaptations, and they do get adaptations quicker in the exercising limb, but the arms adapt as well. So yeah. Kind of in a sideline way answers your question, but yeah. Other questions or thoughts on these so far? Yeah, so back to this study, came out of Norway. This group, Wislof's group in Norway, just does a ton of research on cardiovascular disease and health, all the way from the mouse level up to human level, up to large epidemiological studies. But this was one of the first ones that just kind of shocked the scientific world because they took 27 people who had just had a heart attack, and they made them do HIIT. Right? And so it's like, what? Like that would never happen in the US at that point. But they did 12 weeks, 3 days a week of HIIT or continuous. And they did the 4x4 protocol with these guys too, and girls. It wasn't just guys. But the results were just ridiculous. So their endothelial function doubled, right? So they went from about similar to what we saw, about 4.5 up to about 9-10% FMD. But then look at the VO2 max. Their VO2 max increased by 46% in these subjects, which is just massive. We don't typically see VO2 max increases above like 20% in a study like this, but their hearts were pretty not doing so well to start, so there was a lot of room to improve. Right, so that definitely helped. Ejection fraction went up by 35%. This pro-brain natriuretic peptide is a marker of heart failure. So that drastically decreased as well by 40%. So all of these improved more than the continuous group. So this was kind of the first study to come out to be like, oh, wow, maybe we can actually do HIIT in people who have disease as well. And so it's kind of been slowly working its way into cardiac rehab and things like that, but it's slower in the US than it is in other places. But yeah, May? Yeah, I think it's just a blood marker. Yeah, I think it's just in the blood, like a serum level of that. Yeah. It's called brain. It's not really from the brain. That was just the first place it was discovered. Was in the brain, but it's actually most of it is actually released by the cells of the atria in the heart. And so there's atrial natriuretic peptide as well as brain natriuretic peptide. And so the pro one is actually like a different version of the protein that's been like cleaved a little bit, but that's the one you see more in the blood, I guess. But yeah, the natriuretic peptides are things that are released when you have too much fluid in your system, and that they're diuretics, right? So they're causing people to get rid of fluid, and that's what happens in heart failure is you have too much fluid in your system, and so that's why it's a marker of heart failure. So, yeah. So that was a cool one. And then when I was at ASU, this was one of my colleagues there, one of the ones that was also on that paper that we got to write, Sid Angadi, and he did a similar study to mine, but he did it shorter, only 4 weeks, but he did HIIT versus standard cardiac rehab in patients with heart failure. So and some of those had heart attacks, some of them hadn't, but they all had diagnosed heart failure, specifically diastolic heart failure. But just 4 weeks, so that's only 12 sessions, right, of HIIT. And there's a 3-point grading scale for diastolic heart failure, and the HIIT actually led to a full point decrease on average in the people with heart failure. And there were a couple subjects in the HIIT group that didn't have heart failure anymore after 12 sessions of HIIT. It was It was insane, right? So that's all it took was 12 sessions. And so there's something about pushing the heart to a higher percentage of max, even if it's just for a minute at a time, that that is just something really unique versus just having them exercise at 60% of max heart rate. There's some kind of stress that that puts on the heart that seems to really make it adapt rapidly. So yeah, so those are some interesting studies related to HIIT there. Questions on those? Okay. All right. So a couple other risk factors related to cardiovascular disease. So hypertension. Hypertension is an interesting one where, or blood pressure in general is an interesting one where we have both an acute effect of exercise and a chronic effect. And this is something to think about when we think about the health benefits of exercise, is not just like what happens with 12 weeks of training, but what happens with one session, right? Because the issue with blood pressure is it's always putting stress on our arteries, right? So if we can do something that decreases that stress it puts on our arteries for a few hours a day, then that's great, right? Whether or not there was a chronic adaptation doesn't matter. So what we start seeing is this post-exercise hypotensive effect, which is pretty much you exercise and your blood pressure is lower for a certain period of time for the rest of the day. So an acute bout of exercise, we can expect to see somewhere around a 13 millimeter of mercury decrease for up to 8 hours after that exercise. And so again, some of my colleagues and some of the studies I got to work on at ASU, we were interested in this and looking at this. And so so one of my classmates in the PhD program did a couple studies related to this, where you do something called exercise snacking instead of just a full 30-minute bout of exercise, where you do a few. So in her case, what they did was 10 minutes in the morning, 10 minutes at the middle of the day, and then 10 minutes in the afternoon. And if you can get this hypotensive effect after each of those 10-minute bouts, then you've got pretty much a full day with low blood pressure, right? And so what they did is compare that one to just a 30-minute bout in the morning. And then they measure their blood pressure all day with a blood pressure cuff you have to wear for 24 hours, which is a total pain in the butt because it actually measures it while you're sleeping too. It pumps it up just like it normally would, so it wakes you up. But what they found for sure was that splitting it up into 3 10-minute bouts was better for lowering 24-hour blood pressure than just the one bout during the day. And that's even evolved into lots of other studies like the exercise snacking stuff, which is pretty much, there's been studies where the people do 1 minute of exercise every hour. Like in their day, they stand up from their desk and do go up and down the stairs for a minute, or they just got a little bike under their desk and they pedal for a minute, and do that every hour for a minute, right? And those things have proven to be pretty successful for blood pressure reduction too. So kind of some cool stuff and just kind of creative ways to do exercise. And the bottom line with this stuff is, it's like, just exercise. Like, it doesn't matter. Like, you got options, right? Like if you think about exercise, it's like, oh man, I got to change and I got to go out and do something for an hour and I got to take a shower. I don't have time for all that. Like, just doing something, to go for a 10-minute walk, park your car 10 minutes away from where you got to go instead of right there, right? There you go. You lowered your blood pressure for the next 8 hours, right? So just being able to give people options like that is one of the most important things that we can do, I think, and having a little bit of knowledge about this. So, yeah, so that's kind of the acute effects. Chronic exercise, we expect to see somewhere about a 7 on the systolic side, 6 on the diastolic side decrease in blood pressure. Okay, and I kind of already got into this with the STRIDE trial, but the best type of exercise for a decrease in blood pressure tends to be lower intensity stuff, actually, more moderate intensity exercise. But again, the more volume, the better. So the longer they do it, the better. So going for an hour walk is actually typically better for your blood pressure than going for a 30-minute run. And that's just kind of what it tends to be. Of course, going for a 30-minute run is good for you in many ways. So wouldn't discourage anybody from doing that. But if they're trying to decide one of the two and they think they're not doing enough going for a walk, then you can tell them that's not right. But walking is actually very good for your blood pressure, right? So yeah. So that's blood pressure. Also, cholesterol levels in the blood, very important, right? So dyslipidemia would be the way to say that as a broad term. Physical inactivity has shown to decrease HDL levels by somewhere around 4 to 5%. Okay, so people that are inactive have lower HDL, right? HDL is a good one. All right, so but then exercise, if we do an exercise intervention on somebody, we can expect to see total cholesterol as well as LDL levels decrease by somewhere around 10 to 15%, which is great, right? HDL can increase quite a bit, somewhere 15 or so percent as well. And then the other one that's very predictive of cardiovascular disease is triglycerides in our blood, and that one decreases quite a bit, up to 20% sometimes. So yeah, so exercise definitely just kind of has this full effect on all of our blood lipids, which are all strong markers for cardiovascular disease. Okay. And then when it comes to inflammation, right? And you guys got into this in the paper that you read, but we have this whole set of cytokines, right? So cytokines are pretty much cellular communication chemicals that are released by either immune cells themselves or just by regular cells of the body, and they're communicating with the immune system in some way, either to activate immune cells to cause inflammation or to suppress inflammation, suppress those immune cells. So the ones that would be activating inflammation would be the pro-inflammatory cytokines, right? So there's kind of a whole group of cytokines that are activating the immune system, and there's a whole other group of cytokines that are suppressing it, right? So the pro-inflammatory ones, aerobic exercise tends to decrease all of these, which are things that cause inflammation. But then exercise also increases our anti-inflammatory cytokines, IL-4, IL-10, adiponectin. So yeah, so that was kind of this full anti-inflammatory effect of exercise. Okay, and then lastly, on these two other factors that kind of happen in the end of the progression of the disease, we see blood clotting and then plaque stability, right? We talked about how the last step in when somebody has a heart attack is that plaque ruptures, right? When that plaque ruptures, that leads to a big blood clot, and then that blood clot rolls down somewhere and gets stuck in the heart or in your brain, and you get a heart attack or stroke, right? So aerobic exercise has been shown to decrease the things that, to improve the factors that lead to plaque stability, okay? And so the reason it's a little bit complicated to say it that way is because some of the MMPs we want to increase, some of them we want to decrease, depending on which one it is. So suffice it to say that MMPs improve, which means our plaques become more stable, okay? And then the angiogenic factors, there's two in particular, integrin as well as angiotensin II. Both of those things tend to lead to the plaques getting their own blood supply, right? And so exercise decreases both of those. So plaques don't tend to get their own blood supply, which makes them more stable, less likely to rupture. And then lastly, the clot formation, right? So what if the plaque does rupture a little bit? The state of the blood in the body actually affects the likelihood of a plaque or of that clot actually occurring, or the size of that clot, right? So there's two factors here. Oops, fibrinogen. Does anybody remember where that is in the clotting cascade? What's the last thing that we make in the clotting cascade that's the sticky thing that becomes the clot? You guys remember what that one's called? Huh? Okay, yeah, close. It's fibrin, right? Fibrin is the last thing. Remember, there's all those different proteins that get like cleaved from one thing to the next. The last thing we make is fibrin, okay? And so really all that last step is turning this one, fibrinogen, into fibrin, okay? Fibrinogen is one of our plasma proteins. It's always in our blood floating around, right? It just needs to interact with that one called thrombin. Remember, thrombin's the one that turns it into fibrin. When it turns it into fibrin, then it gets sticky and becomes a clot, okay? But if we have less fibrinogen, then our clots are smaller. We don't clot we're not as likely to clot, okay? And so exercise does that. Exercise decreases fibrinogen. This one is a bit complicated because it's almost like a triple negative. It's called plasminogen activator inhibitor. So exercise decreases an activator inhibitor. So it's kind of like, it's really like three different things you have to work through. But just believe me when I say that decreasing this decreases clotting. Okay. Because if you guys remember, and maybe some of you that I think we have a couple EMTs in here, right? Maybe, yeah. Yeah, do you guys remember heard of the drug TPA? Yeah, tissue plasminogen activator, right? What does that do? When would you use it? You don't need to know the physiology, but when would you use TPA? To break up a clot, is that what you said? Yeah, yeah. In what type of condition typically? Yeah, usually stroke, right? Yeah, so someone has a stroke, if it's a ischemic stroke, right, they got that clot stuck in their brain and an artery. If you get them to the hospital quick enough and they do a CT scan and see, oh, it's a clot, it's not a hemorrhage, give them some TPA, that can break up that clot and save some of their brain, right? TPA is tissue plasminogen activator. Plasminogen is the thing that comes in after the body starts healing that broken blood vessel, and it breaks up the clot for us, right? It's like this little cleanup system that breaks up the clot. That's what plasmin is. So this one, yeah, activates inhibitor, we decrease it. Yeah, that's related to that system. And it helps us break up clots that are already formed, right? But that by decreasing that helps us do that. So exercise decreases that. Yeah, so finish that. Questions on any of that? So we got the anti-inflammatory effect, we got the clotting effect, we got the plaque stability effect, we got the endothelial function effect, right? We got the formation of the plaque effect. All of those different things related to that progression of disease, they're all hit by exercise in one way or another. And the cool part about these two is like, these are, if you've already got a big plaque in your artery, you already have cardiovascular disease, right? So, but what this shows is we can actually improve the ability or just the likelihood of those people having a heart attack, even though they've already got a plaque, right? So it's like, it's never too late in a way, right? To start exercising and start trying to improve somebody's health, even if they've already got these big plaques in their arteries. Right? Yeah. Right. Exercise alone is great. Also, changing the diet will have an additive effect for sure. Yeah, for sure. But if someone's like, I'm just going to keep eating cheeseburgers, sorry. But you can get them to exercise, then that's better than nothing, right? For sure. Absolutely. Yeah. But doing both is better than just one, for sure. Yeah. Absolutely. Yeah. Other questions on any of that? Okay, so we got about 10 minutes left. What I'd like you to do is take that same colored sheet that I gave you last time and flip it over, and just kind of work with your team, connecting the dots of where exercise changes each of those little factors on that sheet. Okay, so yeah, start working through that, and then I'll be walking around a little bit. Let me know if you have questions. Yeah, let me go grab a couple. I've got some in my office. Yeah. Hey, Adam. Anybody else need one of these, guys? Yeah. Yes. Mhm. Oh, shoot. Oh, bummer. Okay. Yeah, that is a lot. Towel. I'll grab some. I'll trade you.
Thank you.
Mhm.
Someone who's like starting to exercise who may already have fat built up in their arteries, would exercising and increasing that shear stress cause the heart to possibly like rupture?
Yeah, so there is a little bit of an increased risk of sudden cardiac death in with like real high intensity exercise with people who have cardiovascular disease, and so it's kind of one of the things when someone's like starting an exercise program to kind of be aware of. But usually if they kind of start out with like moderate stuff and do that for a while and kind of work their way up to more intense stuff, and that's usually kind of the way to go with it. But definitely people that like have symptoms like they might have angina, like chest pain, or have had previous heart attacks, then they would need to like probably start with like cardiac rehab first, with like a monitored setting where they're wearing it, getting the EKG monitored while they're exercising, but then eventually could kind of work their way into unsupervised exercise. But yeah. Yeah. Well, they were monitored too, so they were in a cardiac rehab setting. So they had EKGs on, and so you can see when a heart attack starts happening, and so then they just stop them. Yeah. So yeah. But yeah, that I mean, it would be perceived as dangerous for sure. That's why it had never really been done in the U.S. But since then it has for sure. But there's still a lot of resistance to it in hospitals in general and cardiac rehab centers um, to to integrate HIIT into cardiac rehab. But it's pretty clear it has better effects. So, and if they're monitored, it like doesn't make sense as to why not to add it. So they just don't want to do it. But when it comes to HIIT for somebody with heart failure, I mean, it's like these people were walking at like their high intensity part would be like walking at like 2.1 miles per hour, maybe at like a 1% rate, because that's like its percentage of max heart rate, right? It's not like sprinting at 8 miles an hour or something. No, I mean it was literally like maybe like 2.5 miles per hour, like 1 or 2% grade would be like their intense part, so it's like, yeah, it's all relative. That's the part about it. Yeah. So
I finished copying it all.
nice. Yeah. Yeah. Just showing how exercise kind of affects all those little factors and steps. Yeah.
Like NMPs are doing in this process, like
Yeah.
they improve, but what is that? What are they?
So yeah, so the normal role of MMPs is because normally when tissue is damaged, the cells in the area just lay down a bunch of collagen kind of in like random patterns, and it's not really, it doesn't look like the initial tissue did. So it kind of, it's more like scar tissue, right? So MMPs are supposed to come in, kind of clean that up, kind of smooth it back out. But in the process of doing that in the plaque, it ends up making it just so it's not quite as stable as it would have been. So like the normal healing process is kind of being problematic here. Yeah. That's pretty much it. All right, guys, let's go ahead and come back together here. So if we're looking at all these factors here, we can pretty much make a case for exercise dealing with all of these different things, right? We talked about how it increases nitric oxide over here, right? So then that would lead to a decrease in all of these guys, right? Which then that leads to a decrease in our T cells, decrease in our macrophages, which are eventually going to form foam cells. Right, so that's decreasing the monocyte recruitment. Monocytes are what end up becoming macrophages when they come into the tissues. And so then if we have less of these immune cells, we're also going to have less growth factors, right? So the growth factors are released by the immune cells, and those are what cause other cells to release collagen, right? So we're going to have less collagen. We're also going to have less smooth muscle cells. That was also part of what was caused by those growth factors being released. And that's just all, this is all a normal part of the healing process in general, right? Is like, let's add some new collagen to this area that was damaged. Let's add some new smooth muscle to this blood vessel. But it's kind of just done in an improper way. The MMPs we talked about, those are normally supposed to come in and clean up an injury site, kind of think of it as cleaning up scar tissue, right? And smoothing out that collagen that was just kind of laid down in random patterns during the healing process. But in the process of doing that, it makes the plaque more unstable. And so exercise has an effect on those as well. We also know exercise decreases our LDL. So if we've got less LDL there, we've got less LDL available for those macrophages to engulf, right? We also know if eNOS is doing better, then we're going to have a decrease in free radical production. All right, that's going to affect LDL as well. We're going to decrease the oxidized LDL. All right, that's also going to lead to less of the foam cells. It's going to lead to less cell death in that area, so less apoptotic cells. We know exercise also decreases integrin as well as angiotensin II. Both of those are factors that lead to new blood vessel growth. Right, so exercise decreases both of those things. So we get less new blood vessel growth, which would also help with plaque stability. Okay, we get less fibrin, right? Because we had less fibrinogen. We get less platelet formation that's related to these guys. Those also cause the VCAM and ICAM cause platelets to aggregate around an area. All right, that whole PAI1 thing comes into play up here as well. We get less of that, which is going to lead to a decrease in blood clotting as well, or in the size of clots at least. Okay, we had a decrease in we had improvements in all of the cytokines, which would be directly affecting our T cells and our macrophages here. Less inflammation in general is going to lead to that, right? We had an increase in HDL that was connected to this too. HDL does three things for us. HDL decreases LDL. It also is anti-inflammatory, so it decreases inflammation. And it also is an antioxidant. So if it's an antioxidant, it's going to connect over here to this less free radicals as well and cause less oxidized LDL. This one's a lot, I know. But what we'll do at the end of class on Friday, after we talk about diabetes, is I'll just kind of get us started. I'll draw out a little concept map on a blank piece of paper, blank thing on here to kind of show, because everything really connects in one way or another with this one. So yeah, so we'll do some of that on Friday. But, all right, guys, have a great rest of your day. Yeah.